Welcome back to Curious Conversations. Our guest today is Dr. Gabriel Neves. Hi, Dr. Neves. How are you doing today?
Hey, how are you? I'm doing well, thank you.
Doing great. All right, so before we get into your research, could you tell us a little bit about your background and your pathway to your current position and what you do?
Sure. So my background is specifically started undergrad, got an undergrad major in biochemistry, did research in a neurosciences lab where we studied neurostem cells, tried to utilize their power to mitigate the effects of ischemic stroke on animal models, specifically rats, and then became really passionate about that specific disease and everything else that's followed essentially got me to where I'm at today. So went to medical school, neurology residency, fully trained neurologist, newly minted, and now going into neurocritical care and interventional neuroradiology for the next few steps of my life.
Very cool. And hey, I'm also a biochem major, so on the neuro pathway, I feel you. So very cool. So now let's go ahead and get into your paper, which you recently published in Cureus. And this is the paper titled Deep Learning System Boosts Radiologist Detection of Intracranial Hemorrhage. So let's go ahead and start by defining on a basic level what intracranial hemorrhage, or as you refer to it, ICH, is.
So ICH is any type of bleeding that happens within the boundaries of the skull. So in between your ears, if there's any type of blood in any specific cavity or possible cavity of the brain, that is considered an ICH.
Very cool. And so now we're shifting more towards our usage of AI in medicine, right? And so what has the usage of AI and ICH diagnostics been like in the status quo so far? And what are the limitations of the current usage? And so in your paper, you also address a new type of AI, which is titled Caire, I believe. So how can Caire ICH target some of these limitations that have been found in the past?
Great questions. So the actual use of artificial intelligence in the diagnostic workup of radiographs from patients suffering ICH is a few decades old. Very basic computer vision algorithms back in the late 1990s started to be applied on a purely academic standpoint to see whether or not they could successfully identify ICH is utilizing these technologies, never really walked to a clinical standpoint. So basically, in the past 5 to 10 years, there's been new attention drawn to the field, specifically when companies started to develop strategies to kind of enhance the diagnostic profile of ICH within the context of clinical medicine. And today, multiple centers across the United States utilize AI-backed software that helps them make a quick diagnosis of ICH. And that has translated to some extent into quicker diagnoses. There's not a lot of robust evidence that it's improved patient care, which is the ultimate gold standard of what we tried to do as clinician scientists. But right now, it's very early. I mean, 5 to 10 years pretty early for a technology to get track in clinical medicine. And so to finish answering your question, one of the things that Caire ICH is able to do beyond what the current commercially available technologies have done is we go beyond just simply characterizing a radiograph that shows up as possible ICH. We actually went deeper because if you look at the actual subtypes of ICH, which range from epidural hemorrhages at the very, farthest border from the brain to intraventricular hemorrhages and subarachnoid hemorrhages, which are at the most internal portions of the brain. The management of these conditions clinically is very different, and the etiologies for these specific hemorrhages are very different. So we wanted to see if an algorithm could correctly subclassify the ICH into its individual categories, because that has clinical weight, especially when you're dealing with a patient who is, circling the drain in front of you. You need to know what's the type of hemorrhage so you can better address that condition, whether it may be through a surgical, critical care, or interventional pathway. So that's what we wanted to do with Caire ICH, and we were able to successfully show that this software goes beyond the call of duty of the commercially available softwares and exactly pinpoint what type of hemorrhage it is.
Very nice. And so it sounds like there's a lot of like real world applicability to this new technology. So could you go ahead and then walk us through your paper? Like, what did your results indicate about the usage of deep learning and specifically Caire ICH in this specialty?
Yeah. So that's a very loaded question, simply because of the fact that I think when we try to come up with these technologies, we have a vision, and ultimately, if you follow the natural history of these technologies, the field usually changes your vision on how it's going to be applicable. But I can tell you what we did and how we foresee this improving, hopefully, patient care in the future. So we essentially, when you look at artificial intelligence manuscripts and projects, you usually see a lot of mathematics and statistics to explain the performance of an algorithm given a specific task. And that's very powerful, because ultimately that's what the technology is. It's advanced mathematics and statistics. Now, if you think about it, one of the things that artificial intelligence needs to have is human supervision, and it has to improve human performance in order for it to be valuable. That's what you're seeing with ChatGPT in the commercial aspect of, improving throughput of people's day-to-day mundane tasks in their office, and so on and so forth. So we went above what the traditional AI project does, and we actually show that implementation of this technology as a tool for radiologists is able to enhance the radiologist performance and accuracy of detecting multiple subtypes of ICH. So that's what we wanted to do, because we don't see this as a standalone in medicine, specifically in America with the litigious component of, there's always going to need to be a human supervising these, at least in the foreseeable future. What we wanted to show is that humans are able to be aided by this technology in order to enhance their performance. And by doing that, I think what we intend for the algorithm to do in its clinical applicability is be able to not only be used by the radiologist, but when you look at the acute presentation of ICH in the hospital, what you end up seeing is that multiple subspecialties end up converging on this patient to try to get him or her to a better place. And so what we tend to do is we want to empower all of the physicians, all of the stakeholders of that patient's care in a multimodal way, in order for them to better be able to address the problem at hand. So what we want to show is that we want to show that the radiologist is going to detect these ICHs better, that the emergency room physician, that the vascular neurologist or the neurointerventionalist or the neurosurgeon are going to be empowered by this technology. But ultimately, I think that the goal is to show that not only you're helping these metrics, but you also want to focus on patient-centered outcomes like decreased hospital stay, improvement in functional outcomes after discharge, improvements in mortality. And obviously these are tall glasses, but that's the main goal, is to show that this technology can empower the current practitioner, because volumes are just increasing and they're not pumping out the same amount of trainees that they need to meet the demand. But not only that you can empower these people, and that empowerment will translate to improve quality of life for patients that are suffering from these conditions.
Wow. Well, truly a noble goal. And it seems like your AI is on the way, at least, to achieving this goal. So very nice. And then speaking of a longer scope, well into the future, what work do you have planned in this subspecialty or otherwise?
Sure. So I think that what I really want to continue to do, obviously, is going to be dependent on the success of what I'm currently doing, or the lack thereof, if you will. But I foresee myself really trying to implement similar strategies, but taking into account multimodal artificial intelligence like patient vital signs, biomarkers, neuroimaging, to really better project patient trajectories in the hospital. Because if you look at, there's a bunch of clinical trials taking care of subtypes of ICH, and they're really putting all these patients into a single bucket. But what we're starting to see after these trials fail to show meaningful outcomes or statistically significant outcomes is that there's a lot of individual endotypes within these patients. So I want to utilize artificial intelligence to tease apart these endotypes in order for us to better understand which patients would benefit from one therapy versus another. I think that's where my research is going in the future, is really honing into this subclassification patient trajectory to kind of educate trialists on what are the patients that are most likely going to be benefiting from one therapy versus the other.
Very interesting. All right. Well, thank you so much for answering those research-oriented questions. And I guess to pivot a little bit for the end of our interview, just one personal question. What would you say is your favorite paper that you've written so far?
That's a tough question. I've really enjoyed writing all of them, and but because I don't have like a gigantic library of manuscripts, I can think of one paper that I actually really enjoyed, and it was my first AI stab, which was published not too long ago, where we utilize artificial intelligence to help us grade reperfusions after mechanical thrombectomy in patients suffering from large vessel occlusions. That was a very cool paper to write because I had to read so much. Right, as you're developing technology, as you're developing information, I think you would be remiss not to go into what's been done to better inform yourself so you can make a more robust argument. And I learned a lot by writing that paper, and I think that's when I got bitten by the AI mosquito within clinical medicine and neuroimaging specifically. So I think I would have to say it's my first iteration of an AI paper where we utilize a neural network strategy to grade reperfusions.
Very cool. That sounds interesting, and I'll definitely check it out after this interview. All right. Well, thank you so much for joining us today on Curious Conversations. It was a pleasure to have you.
Thank you so much for having me, and definitely appreciate the work that you guys are doing, and the kind of changing culture that you guys are pioneering within the publishing domain. So thank you for your hard work.
Thank you.